they train their doctors to be experts in persuasion, not just experts in medicine. It can never be at the cost of quality. The doctor's actually incentivized for the patient to be sick. Doctors are swimming in cash. We're gonna try to make humans as good as AI. No one called, no one complained. Why in the world would you do that? This is value-based care. Data and execution.
Hello and welcome to the newest episode of Digital Health Interviews. We continue our journey exploring the American healthcare system and introducing you to key opinion leaders in healthcare innovation. But before I introduce our today's guest, there are two simple things I want to remind you. First, please support Ukraine in any possible way. And second, subscribe to our channel. And if you enjoy watching this video, like it and share with your audience. And now I'm happy to introduce our today's guest. His name is Mendel Erlenwein. Hi, Mendel.
Hello, how are you, Alex?
Pretty good, how are you?
Fantastic.
Let's start with your short intro. Please tell us a bit about your journey and what actually inspired you to become a healthcare innovation leader.
Sure, great question. So I got started in healthcare marketing, actually, right out of school. And I didn't like it very much. The reason was really twofold. Number one, I didn't really know what I was selling. So that's typically an issue. And number two was, I think that there's a common misconception in the sales world that doctors are swimming in cash. And so there's all these ancillary services that are trying to be pitched to doctors. And the truth is, besides for possibly the plastic surgeons and maybe the chiropractors, they're not. In fact, most doctors are struggling to keep the lights on. And so it never felt good to try to come and pitch a doctor on this marketing service that may bring them more patients, may not bring them more patients, needed a bunch of upfront costs, like, okay, we're gonna need this amount of money. And so between those two things, I didn't really enjoy it, and so I never made a sale. So that went on for about 2 years. I did have work because I was supporting, it was a company that was part of kind of a larger healthcare conglomerate, so there was different pieces of the puzzle. So I was doing a lot of supporting marketing work for other companies in the network, so to speak, but not really making any kind of external sales. And so that lasted about 1 year and 8 months, maybe about 2 years. And shortly after ending that chapter, the opportunity presented itself to take over a care management company. And they were doing, the company was doing a little bit of chronic care management. There wasn't very many patients. It was, the company was actually in the red. It wasn't really making money. Mm-hmm. And there was just a couple issues internally that was making it impossible to scale. And so the person that started the company, fantastic guy, he decided to move on. And so the company was kind of just sitting there. So the opportunity presented itself for me to take over this project, which I decided I would do. And that was about a little over 4 years ago. It's been a lot of fun since. We've brought everything in-house. We're talking about 5,000 patients a month now, and building out a great company culture. And it's been a lot of fun. And so that's kind of been the journey for Previva Health Group. Is now the company has rebranded a couple years ago. And that's really the bulk of my day-to-day. Amazing.
Let's kick off our conversation with a topic that is probably the closest to you, and you've probably talked about it a million times already: value-based care versus fee-for-service model.
Yep.
Tell us a bit about what are the differences and how both models work.
Sure. What value-based care looks like is it's essentially an incentive model, or it's a model that aligns the incentive for the doctor with patient care. So it aligns both. And so what you're used to, like you mentioned, is something called fee-for-service. If something breaks, you go to the doctor fixes the thing. If you go home and it breaks again, you go back to the doctor fixes it again. And each time, the doctor gets paid, right? So if someone has some sort of procedure or operation, doctor gets paid, they go home, they get some sort of post-op infection because the care wasn't necessarily great coming out of the hospital. They go back, doctor gets paid again. So if you think about it, the doctor's actually incentivized for the patient to be sick rather than healthy, because that's when they get paid. And so Then you've got other voices that are like, doctors are making too much money, we should take money out of healthcare. And I think in America, that's not a viable path to kind of go down. And so I've had some very interesting conversations with some people from the Netherlands and other parts of Europe where they have different models of healthcare, and you seem to explore the various models. And there's a very interesting cultural difference that we could talk about if you'd like. But not to digress, what value-based care looks like is it says, okay, in the most extreme version of value-based care, we say, we're going to give this health system, let's call it the doctor, a amount of money. Let's call it $1,000 for Alex's health. And we're going to give the doctor that money, whether you're healthy or sick. Okay? But the catch is the doctor or the health system takes responsibility and takes liability on your health outcome, which means that I'm accepting that money, but now I will pay for your health care. And so if God forbid you end up in the hospital, I'm footing the bill. And I think the average hospitalization is like $17,000 or something like that. And what that does is it shifts the entire thing on its head, where now my job becomes two things. My job becomes lower costs, so I need to spend less than $1,000 on your health in total, and higher quality. And usually when you're hiring quality, it's with a huge focus on preventive care. Because I'm going to start thinking to myself, okay, if there's an elderly lady that's one of my patients, I'm going to pay, so I have $1,000 to spend. I'm going to pay $20, let's call it, I'm going to spend $20 to have somebody call that lady, talk to her once a month. And then during the conversation, we ask a couple questions, and it comes up that lady doesn't have a bar in her shower. And so I'll spend another maybe $50 to coordinate for a bar to end up in her shower. And that all financially makes sense to me because I just statistically saved that lady from falling and breaking her hip, requiring a hip replacement surgery that in a fee-for-service world would have been the best thing ever for me because I would have just made $100,000 on a surgery. But in a value-based care world, I just would have lost $100,000 because I would have had to foot that bill. And so it flips the whole model on its head where now, leaders in value-based care are thinking, where can we manage our patients the best for the lowest cost, but it can never be at the cost of quality because then you just shoot yourself in the foot. So you're always pulling those two levers. And so that's kind of, does that make sense?
It does. I assume that everybody wants value-based care as a patient, of course. But it probably comes with lots of challenges. What are some common hurdles that come and how basically providers can overcome them?
Yeah, so first of all, patient-facing, and this is actually something that I've been exploring, whether patient-facing this is even a very understood concept yet. I think most patients are living their life. They're going to work, they're coming home, they're trying to live, they're trying to survive. They're not necessarily keeping up to date on the various reimbursement models in healthcare. And even for doctors, a lot of doctors don't really understand or are exposed to this model yet. It kind of sits at the health system level right now. Mm-hmm. And so you have a lot of, there's multiple really fantastic straight value-based care organizations. There's ChenMed, Oak Street Health, just various organizations that are really straight value-based care and doing a fantastic job. And then there's other organizations like Northwell and other large systems that have like verticals of value-based care within this system. To answer your question, the biggest challenges of adoptability is that we have an entire health system. I think we're $3 trillion or $8 trillion cost right now in totality. That's entrenched in fee-for-service. And so the reimbursement model is like that. The thinking is behind that. And so it's so deeply entrenched with the practices and the way that the physicians and the coders and the billers and all the staff, the way the entire system is constructed is around a fee-for-service world. And so to flip that on its head, because it's literally flipping it on its head, is a very challenging thing. There's a couple leaders that have successfully done that and are successfully doing that. Of note, there's Dr. David Pate, who was the CEO at St. Luke's Health System, and he managed to, first of all, over 10 years, grow them from, I think, $1 billion to $3 billion in revenue. But he managed to create a third of their revenue, so $1 billion of that, into value-based care from within the confines of a fee-for-service organization. So that's really challenging. Another fantastic doctor, Dr. Zena Brown from Northwell is doing this right now with Northwell. She's leading a lot of value-based care initiatives for their value-based care vertical. And so, and what I described is also with the flat rate, that's kind of the most easy to understand extreme version. And of course, there's a whole gray area in between. So maybe a doctor's taking accountability and liability on a specific procedure. So if you're going to do the surgery, then you're responsible for any kind of post-operation care or something like that, which kind of makes sense. It's almost like having a warranty on a very expensive product, if you think about it, right? And so, but yeah, adaptability is difficult because the whole system is entrenched around around fee-for-service.
So if I understand correctly, if we put adoption of value-based care on the scale from 1 to 10, where 1 is like very early stage, and 10 is like already super adopted, where we are at 1?
No, probably a 3.
Okay.
Probably a 3. It's definitely gaining traction. CMS or CMMI has put out earlier this year or last year that they expect every healthcare organization to be part of some sort of value-based arrangement by the year 2030. So they're aggressively pushing the country in that direction. I think what remains to be seen still, which is actually not talked about, is the actual efficacy of the program and whether it's actually driving down costs. And so there's a lot that really remains to be seen, but conceptually, it just seems to make so much sense, right? And so conceptually, aligning patient care with physician incentive makes all the sense. I was a couple months ago, I was at our offices in Brooklyn, and I stopped by the water cooler, and I noticed this little card sitting on top of the water cooler. It was a handwritten card, and it said, it was dated 2 days prior, and said on this date, with the name of a technician, let's call him David, came to this office. This is the preventive maintenance that he did on this machine. And it was listed a whole bunch of things. He cleaned the inside of the machine. He cleaned the outside of the machine. He checked for this. He checked for that. He did a bunch of stuff, right? And I was like, this is value-based care. Why? Because you would think to yourself, why in the world would a for-profit company spend money to take a technician in Brooklyn, send them out to some random office building that has one machine? There wasn't 500 machines. There was one machine, right? And in Brooklyn, which if you've ever driven anywhere in Brooklyn, it's not the easiest thing, right? And so send this person out, pay that time for them to go to this machine and do things for the machine maintenance-wise when it's not even broken. No one called, no one complained. Why in the world would you do that? And the obvious answer is that obviously they are the ones that are responsible for switching that machine out if it does fully break. So obviously they've determined that if they do these small incremental maintenance, they will actually get a lot more life out of that machine. And in the long run, they will save more money that way than rather switching out the machine every time it breaks. And so again, in that example, the financial incentive is aligned with the care, because they're like, okay, where do I make more money? If the machine totally breaks down and I switch it out once every 6 months or once a year, or if I do small preventive maintenance things and spend a little bit of money, but that gives me 5-year lifespan on the machine, right? And so if we can think like that with healthcare, we're gonna be able to really impact patients, I think, very positively.
And great example. Thanks for that. You've already named a few companies that operate in the value-based care market in the US, but apparently they're working against the traditional system of fee-for-service model. What makes them successful?
Data and execution is my opinion. In order to execute properly and create a successful value-based care organization, you have to have systems in place to have proper data on your patients, to be able to break down who your sickest patients are with the highest, complexity and chronic conditions. And so that's step one, is identifying who is costing me the most money from a care perspective. Mm-hmm. Then you have to actually have the operation to then target those people and manage them so well that you drive down those costs. So if this demographic is consistently ending up in the ER, that's obviously going to cost you tons of money. And so that's where a lot of the prevention, that's why prevention is so key in value-based care, because a lot of it comes down to, okay, maybe we probably should call all of our patients turning 50 and get them to come in for colonoscopy, because chances are we are going to catch X amount of early stage cancer then, which we will deal with, and now less late stage cancer will end up through the funnel, and late stage cancer care is going to cost a whole lot more than taking care of it early. And so, you start thinking in a whole different way. There's a friend of mine, his name is David, and he built a tremendously successful value-based care operation. He sold it for a ridiculous amount of money. And he told me, one of the most powerful things that he told me is, he said at one point he had a doctor, full-time salary. The doctor's entire patient panel was 7 patients. 7 patients. Mm-hmm. And he said, why? Because he knew how to run the numbers and he knew how to run the data. And he determined that those 7 patients were costing him $2 million a year in care. And so it totally financially made sense for him to pay that doctor $250,000, $350,000, $400,000, whatever that salary was, to go and just manage the hell out of these patients so that they never end up in a hospital. And that and that drove that, and now he has all that spent. He's able to, anything that he brings down from 2 million is going to be cost savings. So it just flips the whole mind and the way you approach care.
All right. You already talked about Previva Health Group. Can you elaborate what specifically services do you provide?
Sure. So at Previva Health Group, we run those 5 preventive services: chronic care management, otherwise known as CCM, remote patient monitoring, annual wellness visit support, transitional care management, and behavioral health integration. We'll start with the primary program, which is chronic care management. What that looks like is it's a Medicare-funded program, and so the reimbursement is about $62 per patient per month to a doctor. And the eligibility requirements are that the patient have 2 or more chronic conditions, has been seen in the office in the last 12 months, and then obviously has correct insurances in order to actually pay. And the idea is that you pitch the patients on the program, they choose to opt in. And if they opt in, what the actual program looks like is you build a care plan. And so the care plan is going to revolve around the 2 chronic conditions that the patient has. And it's going to go through their goals, their challenges, what are they trying to accomplish, understand kind of understand what resources they have available to them, understand who they talk to, if they have family, if they have friends that they're talking to, understand their medication regimen. And then you are doing a preventive call to the patient every month and the total care time is a minimum of 20 minutes. And you're following up on that care plan. You're trying to have the patient make some progress on their goals. If it's lowering their sodium intake, or if it's going on a walk, or if it's exercising more, losing X amount of weight. And you try to get them to move on those goals. You talk to them every month. They should always be able to call back. There's 24/7 access back to the care team. And you can also help them, if they need a medication refill or an appointment request, and just make sure that you're catching things that would otherwise fall through the cracks, as well as try to proactively move them on their health goals. And this really, really is super effective with keeping patients out of the hospital, because they're better managed proactively. If they ever have an issue, they know who to call, and it's not going to be the front desk that's just going to ring forever and never pick up, or send them to a robot. And it's been very effective to keeping the patients out of the hospital, which is the goal.
Amazing. I know that you started another company a few months ago.
Yeah.
It's called Soapnotes.
Yeah.
Tell us more.
Yeah, super excited about Soapnotes.ai. So on the Previva Health Group side, we have this care coordination company. And so I watch our care coordinators, who are fantastic every single day, and understand their pain points and the way that they're able to be effective with the patients, the way that there's where there's areas to improve.
But now you want to substitute them with AI.
Not at all. Not at all. So to that point, then I'm watching the AI space very carefully. It's obviously a crazy buzzword right now. And I'm seeing a lot of people that are trying to do a lot with AI. And in my estimation, some people are trying to do too much with AI. So the way I think about it, I take a care coordinator and split them down the middle into heart and brain departments. And I think that the human being has a unique value proposition in the heart department. And by heart, I mean the personality, the empathy, the delivery of care, the care coordination. And obviously AI has a unique value proposition in the brain department, the ability to process ridiculous amounts of data. And so I see some people that they try to have the brain do everything. And I think that's a big mistake. So to your point, replacing the human, I think is a mistake. Other people don't recognize the brain, so they have the heart doing everything, and that's simply inefficient, because there's some things that we're just not good at. And so our mission at Soapnotes.ai is to build out the brain of the care coordinator to amplify their heart. So our mission is build the brain to amplify the heart. And not only to not get rid of the human element, but to just amplify its ability to be that much more impactful. And so what we're doing practically is we're building out this brain, and that's all you need to know about the company. Whatever you could think of, what would be the perfect care coordinator's brain, that's what we're building. So we're building this omnipresent application that understands patients' care plans, their goals, their challenges, all that context about the patient. It has parametered education around those chronic conditions that the patient might be suffering from. And it's also listening into phone calls between the care coordinator and the patient. And so given all that context, it's able to actually create a hyper-personalized call plan for the care coordinator. So before the care coordinator picks up the phone to talk to the patient, they click a button and they're spoon-fed specific questions and pieces of education to give the patient and to ask the patient that are designed by the brain to not only move the patient on their health goals, but also seamlessly picks up from the conversation last month. And then when they hang up the phone, it spits out their soap notes. Now they have their documentation and their action items. But the really important part is as we're building this out is including behavioral science and persuasion techniques and human psychology to build the brain in a way that it's prompting the care coordinator to provide such a level of excellent and efficient care that is simply impossible to provide as just a human. An example that I think, and this is my idea as a non-behavioral science, but just an example. Imagine if, one of the things that I find challenging about healthcare is that, especially in a value-based care environment, the doctor is incentivized for the patient to change their health decisions, right? And so take the chronic care management program that I described earlier. Imagine if you were going to your financial advisor and the dynamic of that conversation was that your financial advisor was begging you to sit down with them for 20 minutes a month to talk about your financial health, right? You might sit down with them, you might not, but you would leave the conversation and go continue racking up debt on your credit card because it would go in one ear and out the other, right? And that's the dynamic of healthcare. You have a provider or a healthcare organization or a care coordinator at whichever level that they are the one that's incentivized for this patient to change their diet, to exercise more, to do these various things. And that's a weird dynamic. And so one of the things that I aim to solve with Soapnotes.ai is to build this brain in a way that we're almost hacking patients' brains and almost, not in a good way, manipulating the direction for them to actually change their health habits. And so an example of that, again, this is as a non-behavioral scientist, but an example of that would be, imagine on that 12-month chronic care management plan. Imagine if for the first 3 months, we didn't even talk about the plan. Imagine if for the first 3 months, we only talked about the patient's why. Why do they want to manage their diabetes? Why do they want to, have more energy? Is it because they want to be at their grandchild's graduation? Is it because they want to walk their daughter down the aisle? What are those reasons? Now, 3 months later, first of all, we've built a relationship with the patient. And second of all, we're now both showing up to that conversation with an equal amount of emotional equity in that conversation. Now, we can actually do something with the patient, right? And so as a human, it's extremely difficult to, it's impossible to track for 300 patients that you speak to a month. It's impossible to track, okay, for 3 months, I'm going to do this. And that's just one example, right? But by building this one synchronized brain that's able to keep track of everything and then prompt the human. And so we are able to do that. And so while the whole world is busy trying to make AI as good as humans and have humans prompt AI, I'm trying to go in the opposite direction where we're going to try to make humans as good as AI and have the AI prompt the human.
Feel like an ex-unicorn in healthcare, right?
I'm excited about it. We're, good traction so far, really, really good results. Efficiency is really through the roof where this is implemented already. Mainly quality is going up. And so the quality of the phone calls, and that's just going to continue to get more and more as we build this out.
Congrats on your success with Healthcare Trailblazers podcast.
Thank you.
I highly recommend to subscribe to Mendel's YouTube channel. Lots of great and useful content about value-based care, digital health, and much more. Among all the people that you've interviewed or any other people that operate in the space, name a few names of leaders that fascinated you the most over the past few years that actually made biggest contribution to digital health innovation?
Sure. Again, I've really been blessed to speak with tremendous leaders in the space. On the public side, we've had the Chief Medical Officer of Medicaid, the Chief Transformation Officer at Medicare, the Chief Innovation Officer at CMMI, which is the Innovation Center for both. On the private side, so many great conversations. So many. Just yesterday, I don't know when this is going to go live, before or after this, but just yesterday, I had the chance to have John Kao who's the CEO and founder at Alignment Health. It's been fascinating talking to all these people. I think some of the most impactful, yesterday's conversation is obviously most fresh in my mind, and I think that the passion that really shines through with John from Alignment is tremendous. And so for me to talk to these leaders, it's really heartening to see that so many of them really, really mean it, and they're really in it for the right reasons. And I think probably the conversation that I've repeated the most would be with Gordon Chen from ChenMed. And he talks about, and a lot of that is kind of what I want to build into this brain with Soapnotes. And he talks about how he basically describes that same issue. And he says that, when you're taking liability over patient's health outcome, you have to change their health outcome. And that's a huge challenge for the doctor. And so the line that he said that I repeated so many times is that they train their doctors to be experts in persuasion, not just experts in medicine. So to be doctors of persuasion. And I think that's such a powerful concept. And so that's been a super impactful one.
All right. Finally, what kind of pieces of advice would you give to digital health startup founders according to your experience?
It's a great question. I think first and foremost, have the end user in mind. If you're creating technology for nurses or for doctors or for clinicians or for patients, make sure that you really, really understand them and their behaviors and the way that they're going to use something. Because a lot of people come into the space from a technology perspective and they look at healthcare like, oh, here's a ton of opportunity. I'm a tech guy. Let me just create some sort of device or technology or software. And a lot of them miss the mark with the actual end user. And this is a frustration that I hear from a lot of different people on the clinical side. And so that would be, I think the first thing is really have a deep dive, have representation from your end user on your advisory board or people that you speak to, and make that definitely a priority.
This is great. Thank you for the amazing conversation and all your insights.
Absolutely. Thank you, Alex.